Onc Live Insights is a video editorial program produced by Onc Live.
For most patients who have non-squamous histology, we at least talk about giving pemetrexed, and sort of my fall to regimen for these patients is carboplatin, pemetrexed, followed by pemetrexed maintenance, or those two in combination with bevacizumab. For patients who who are unable to receive bevacizumab at all, I think that's a very appropriate frontline option. I think it becomes much more difficult for patients with squamous cell tumors. So we have some data from Panos Phidias looking at carboplatin and gemcitabine followed by docetaxel maintenance. This was a trial that improved progression-free survival. He found, however, that if patients got docetaxel right on the heels of chemotherapy versus delayed until progression, those patients that received the chemotherapy actually had equivalent outcomes. The problem was that many patients weren't able to get to that second-line therapy because of either catastrophic brain metastasis, pulmonary embolism, deterioration in performance status. So they just weren't able to reap that survival benefit. The trial wasn't able to show an overall survival benefit, but certainly these are intriguing.
There are two different types of strategy after 4 cycles of chemotherapy. There is what's called continuation maintenance, where patients are given the same drug that they were given in the induction regimen, but the platinum is dropped. And what we've seen from that is that there is a survival advantage, and that is from the Paramount data suggesting a 3-month, close to 3-month advantage in survival. The other strategy is switch maintenance, in which patients receive a platinum doublet that doesn't contain the agent that you're going to deliver next, and some people call this early delivery of a second-line drug. And what we know from that strategy as well with pemetrexed is that patients garner a survival advantage. And in the JMIN study, we saw close to a 5-month benefit in overall survival, specifically for the adnos. So those are two strategies that can be employed. I think what we know about bevacizumab is that that is a continuation maintenance regimen, and in the ECOG 4599 we saw again there was a survival advantage by including bevacizumab in the induction regimen and then dropping the platinum taxane and continuing the bevacizumab. So clearly there are competing strategies, but to date the only cytotoxic drug that's approved for maintenance it has been pemetrexed, and it's very well tolerated. I generally give chemotherapy, maintenance chemotherapy, right after their 4 cycles of induction. There are some physicians who believe that a treatment holiday is important for patients and that they can deliver drug upon progression. I think if we employ that strategy, we know from clinical trials that up to 30 to 35% of patients don't ever receive drug employing that strategy. So I think it's important to deliver chemotherapy, maintenance chemotherapy, right after 4 cycles of chemotherapy. And that's why it's so important to initiate that discussion at the beginning of treatment, that patients are aware that after their 4th cycle of platinum pemetrexed, 3 weeks after that, if the scan shows stable disease, that they're going to continue on a drug.
I think if we all knew when a patient was going to progress, we'd love to be able to give them a true treatment holiday. The fact is that often we think patients are doing great, and 6 weeks later when they come to see us, even if if they've been recovering from chemotherapy, they may have a few minor symptoms. We do a CT scan and we find that they have significant progression. Or it may be that in 6 weeks they develop brain metastasis with that treatment break. It's very individualized, and it's difficult to find the best maintenance therapy for all patients.